So we talk about pulmonic stenosis now, and the evaluation is almost like an aortic stenosis. Here, although we do not use anything like continuity equations or something like that, the most easiest or most friendly valve, which I always feel, is pulmonic valve. So let's look at how pulmonic stenosis behaves like. It has got again 3 leaflets, and interrogation is parasomnal short axis view at the level of aorta. Then this nomenclature is very difficult. What we see in pulmonic valve in parasomnal short axis view aorta is this is anterior leaflet, this is left leaflet. We often ask this question during our examination times. What is this leaflet? What is this leaflet? And majority of even examiners, they get confused. What is this leaflet? Because everybody says this is anterior, this is posterior. This is not posterior, this is left leaflet. So this pathology is important because when we look at this pulmonic valve, we look at these one leaflet, and the second, obviously we cannot look the other one. We have seen anterior, we can see a left leaflet, and we cannot see the right leaflet at all. And this is possible today in 3-dimensional echo. So we have anterior and then left and right leaflet, and what we see is anterior is to anterior and left in this particular fashion over here. So in pulmonic stenosis, as somebody was asking, we have pulmonic stenosis per se, then subpulmonic stenosis, then suprapulmonic stenosis. Now look at subpulmonic. Somebody was asking, like, what is subvalvular aortic stenosis? Subvalvular aortic stenosis is any stenosis before the valves. So same as subpulmonic is any stenosis before the valve. There we used to call LVOT, and here we used to call RVOT. Look, here is a mass, a muscular band at the level of RVOT to produce a subvalvular stenosis. If I switch on a grade, this is a 3-dimensional picture, you can see a better or muscular band in the subpulmonic area, in the RVOT. And as soon as I keep my sample volume at that particular point, what happens? It gives me a flow velocity, which is severely aliasing. And I cannot contain with a pulse wave Doppler spectrometer. These are two separate lines. And lot aliasing is happening in this particular fashion. And that's what is subpulmonic stenosis. And this invariably presents like double chambered right ventricle. I'll show you an example for that, DCRV, and along with VSD. That's what is seen number of times with this kind of pictures. Then comes supravalvular. It means apart, here's a valve. The lesion is at the level of distal to the valve. That is supravalvular in pulmonic artery. That was an RVOT. Here is pulmonic artery. Look here, RVOT is clean. This is supravalvular pulmonic stenosis. Now look carefully. I've tried to zoom up this picture by another image. The valve is over here. The blockade is over here. That is supravalvular. If same thing is seen in aortic valve, we call them as supravalvular aortic stenosis. Here the turbulence is seen, but only thing is the blood has to pass through these narrow openings. And if I put my continuous wave Doppler, I'm going to get a gradient of almost 4 meters per second. Now, anyone, if you can get up and ask me, how do you really say that this gradient is coming from this point, not from this point? The best answer is take a pulse wave Doppler spectrum pattern and keep that pulse wave Doppler spectrum pattern over here. Move from here to here. As you move from this valvular to supravalvular region, you start seeing the aliasing of the Doppler spectrum pattern. And when you start seeing the aliasing, then you change your scale of the Doppler flow velocity, make it highest possible, move the baseline up to contain the Doppler spectrum pattern. If you can't do that, switch over to continuous wave Doppler. And that's what exactly is supravalvular aortic stenosis. Once we have done with the subvalvular, we have done with the supravalvular. What is left behind? Here is this valvular pulmonic stenosis or valvular stenosis per se. Now you can see beautifully the jet is eccentric. This is what was anterior cusp. This is left cusp. So jet is eccentric and is a level of turbulence which is similarly seen out here. And the Doppler spectrum pattern by continuous wave Doppler gives you a velocity of almost 3.18 meter per second. Anything more than 2.5 is considered as abnormal. Now causes, essentially a congenital. It is associated with multiple lesions: isolated pulmonic stenosis, VSD with PS, tetralogy of Fallot, trilogy of Fallot, many conditions where we find this kind of abnormalities. Then certain tumors which are localized to right side of the heart, like carcinoids, they will affect tricuspid valve as well as pulmonic valves. So you could be the tricuspid valve carcinoids affecting these two valves, presenting as stenosis of this tricuspid as well as pulmonic valves. So that is a good way of looking at this right-sided lesions. T is almost sufficient. Rarely we do a transesophageal echocardiography in this. So what we look at: valve anatomy, hemodynamics, hemodynamic consequences, and symptoms. What is valve anatomy? Thickened, distorted, possibly calcified leaflet with systolic doming and reduced excursion. Other associated abnormalities may be present, such as narrowed RVOT. Hemodynamics, if anything more than 4 meters per second, that is 64 millimeters of mercury, that's a peak velocities. What is the consequence of hemodynamic consequences? You have right ventricular hypertrophy. If the right ventricular hypertrophy is not able to take care of everything, RVRA enlargement will start happening. And on the other hand, post-stenotic pulmonic artery dilatation can be seen. Symptoms, almost negligible. Majority of people, they do not have a symptom till they start developing a feature of right-sided failure or obstructions. One more variety which I wanted to show you. This is a variety of peripheral pulmonic artery stenosis, which is often seen in neonates. What exactly happens in neonates? The neonates pulmonic vessels, they are tuned to blood vessels. These vessels are not tuned to high flow of blood flow, because suddenly they are exposed after birth to a lot of blood flow in the pulmonic vessels. They initially behave like a peripheral pulmonic artery stenosis. As seen, the left pulmonic artery is over here, the right pulmonic artery, you can see a turbulence in the right pulmonic artery. And this disappears over a period of time, majority of time. This do happens, and we do see in day-to-day clinical practice. So whenever I talk of pulmonic stenosis, I say 4 types of pulmonic stenosis is present: subvalvular, valvular, supravalvular, and peripheral pulmonic artery stenosis. So here is the example for that peripheral pulmonic artery stenosis. How to assess PS? I showed you already. Parasternal short axis view at aorta. It could be subpulmonic, pulmonic, or suprapulmonic. VSD can be seen, and measure the peak velocity, not the mean velocity. That is the only one valve where we do not measure the peak velocity, mean velocity. We always measure the mean velocity of the pulmonic valves. So we are measuring the mean velocity of the pulmonic, peak velocity of the pulmonic vein, and this peak velocity has to be more than 4 meters to call it significant, as significant pulmonic artery stenosis. That's all in pulmonic stenosis. I would be happy to take up questions from any one of you. So let's start asking questions, or I'll ask the questions.
Sir, the views, sir, how do we get it?
Pardon?
How do I get that long axis view, short axis view of the pulmonary valve? I was going through the book. How do we get it for pulmonary valve?
Short axis view of the pulmonic valve? Whatever I've shown you, always I've shown the parasternal short axis view at aorta.
Achha.
This is parasternal short axis view at aorta, because that's the only view you'll be able to see a pulmonic artery.
Sir, I was going through the book. It was saying there is short axis view of the pulmonary valve. Is there any other view of this?
Yeah, you can make a short axis view of the pulmonic valve by rotating this cursor to almost 90 degrees. But that is not for you. Forget about that level.
Okay, sir.
Yes, sir.
Pooja, go ahead.
Yes, sir. Is there a role of measuring the thickness of the pulmonary valve, sir?
No role.
And doming?
No role. You can say thicken and dome. And any principle of thickening is any valve more than 5 millimeters of thickness.
Okay, thank you.
Sir, to look at RVOT appears to be more in diameter than LVOT. Is it true, sir, or is it just a I I like where we see that's the situation?
No, let me just come out the normal values of LVOT and RVOT. I said LVOT diameter annulus is almost 1.8 to 2.2 centimeters, right? The highest RVOT diameter is 2.6, 2.7 centimeters. So, in true sense, it is always bigger than LVOT.
Yes, sir. It looks like that, sir. That's why I
It
asked.
is bigger always, like measurement wise also, because we take whenever the cutoff comes more than 2.7 for pulmonic valve, then we start saying pulmonic artery is dilated.
So RVOT and pulmonic arteries, sir, diameter which would be RVOT would be larger than the pulmonary artery, sir.
RVOT, pulmonic artery and RVOT almost same thing, 2.2, 2.6, 2.7.
Okay, sir. Sir, why does this occur? This why is it thicker than LVOT? Any
Why is bigger than LVOT?
Yes, sir. Yes, sir.
LVOT gives rise to one vessel, that is aorta, and pulmonic artery gives rise to two vessels, that is right and left pulmonic artery.
Okay, sir. Okay, sir.
Sangeeta, you want to ask some question?
Yes, sir. Sir, is there any difference when you say that the valve is closed and we say the valve is thickened? They are the different things.
Oh,
sir?
no, this terminology is almost the same, like if we happen to see a younger person, like I said pulmonic stenosis is majority of time is congenital.
Yes, sir.
And over a period of time, these valves, they're subjected to trauma because of the constant flow and constant of their opening and closings. If I happen to see a valve which mildly increased flow velocity at the age of 65 years, and this appears to be thickened, and with a velocity of 2.2, 2.3 meters per second, I'll say sclerosed or degenerative pulmonic valve.
Okay, sir.
Correct?
Right.
Same for aortic stenosis. If I happen to see aortic stenosis by birth, there'll be parachute mitral valve, no, not parachute, bicuspid aortic valve versus the valve which is seen at the 65 years of age, which is thickened, which we say degenerative aortic valves.
Sir, how about the tricuspid valve diameter, sir? We compared to that is the mitral valve. There we measure by 220.
Yeah, good question, Dr. Hitnagni. That mitral valve annulus diameter is 3.3, tricuspid valve is up to 4.0.
How do we measure, sir? Unlike their 220 by PhD here, how do we go about here?
Measure what, dear?
Tricuspid valve area, sir.
We do not measure tricuspid valve area.
Oh, okay, sir.
If I have to measure my tricuspid valve area, I have to go to 3 dimensions planimetry.
Oh, okay. Okay.
That's
sir.
why in tricuspid valve we talk of a mean gradient, pressure half time, area by pressure half time, and a mean gradient of more than 5.
Okay, sir. I got it. I will read, sir. Thank you.
Planimetry we do not do in tricuspid.
Yes, sir. Thank you.
Sir, pulmonary jet is corresponds to pulmonary hypertension, sir. Is there pulmonary jet, sir?
Pulmonary jet
measure.
will correspond to pulmonic stenosis. Pulmonary hypertension will correspond to TR jet.
Okay, sir. Okay, sir. Thanks.
Sir, what is the
Let
role?
me ask you one question. Don't go away, Venkatesh.
Yes, sir.
Suppose you have an aortic pulmonary stenosis with TR jet. Suppose you have a pulmonary artery hypertension, pulmonic stenosis. What you label as pulmonic hypertension as?
We will add on, sir. +5.
No, will reduce pulmonic stenosis jet. Man, if TR jet gradient is 64 and the pulmonic
Yes.
stenosis gradient is 36, so 64 minus 36.
Okay, sir. Thank you, sir.
Go ahead.
Hello, sir.
Yes, go ahead.
Hello, sir.
Sir, can you hear me?
You have to speak a little loud if I could.
So actually,
Listen.
my microphone is not working. That's why I was not able to talk all this while. So you were telling some pitfalls for aortic stenosis.
Mhm.
You tell again. I mean, what all we have to keep in mind?
Pitfall for aortic stenosis is only a few of them. First of all, you have to measure a proper LVOT diameter.
Yes, sir.
Second important thing is you have to have a perfect ejection fraction or LV function. Because if your LV function is low, you are going to underestimate your aortic valve gradients.
Okay, sir.
And the third most important part is to look at the peak velocity across all 6 different windows.
Okay, yeah. All the
If you
6.
happen to measure only 2 or 3 and you're in a hurry, you forget. At one time we studied which is the best window where we can look at this aortic valve gradients, So we found the aortic valve gradients are best seen in right parasternal windows.
Right parasternal. Okay.
So
Does
efforts to look at all these windows together.
okay, sir. If somebody has a diastolic dysfunction, does it affect that?
Diastolic dysfunction, majority of these AS people will go to diastolic dysfunction automatically.
Okay,
It will not
consequent.
affect measurement, but majority of these people, because what happens when AS is present, LV relaxation will become poor. If the
Yes.
LV relaxation will become poor because of hypertrophy, what will happen? The LA pressure will start building up automatically.
Hmm. Okay, sir.
Sir, hello, sir.
Yeah, go ahead, Raj.
Sir, is there a role of M mode for pulmonary valve?
Believe my word, there is a role, but I do not know how to do it. I have not done it all.
Okay, sir.
Certain things which I do not like and do not do at all, this is one of them.
Yes, sir.
When I can see a beautiful images of pulmonic stenosis, why the hell I should do a M mode across pulmonic valve? That's how I feel.
Yes, sir.
Like today, like many people, they still do ejection fraction by 2 dimensions Plaques window. And when I say like when I can have an ejection fraction by automatic ejection fraction by 4-chamber, 2-chamber view by my machine, why should I
Yes.
go to and look at my Plaques window to call ejection fraction, M mode ejection fractions?
Yes, sir.
So the same thing, I do not do it.
Okay, sir. Thank you, sir.
Sir, is it that all the stenosis people should undergo TE, or I mean, should we subject all of them to transesophageal echo for better measurements and
For what?
gradients?
In pulmonic or aortic?
Patients with aortic stenosis.
We hardly subject
mean,
patients to
aortic.
aortic stenosis for transesophageal echo. Rarely,
I mean, it's
once
not
in
okay
thousands.
required.
Because Doppler gives you a very good value. Where we have some problems, like I showed you one example. That then only I subjected that patient for transesophageal echo.
Okay.
Otherwise, the transthoracic is fairly good enough to give you everything. One more important thing I'll say is when I go to severe aortic stenosis and my gradients are high, but my area comes out to be low, I've got to be very cautious. If my gradients are high, it means I'm dealing with severe aortic stenosis, but my area is coming as less than like 1.5 or 1.7. Then I really become cautious whether my LVOT diameter is correctly calculated or not. So I take a help of CT, cardiac CT, to look at my LVOT diameters.
Okay, sir. Got it.
Sir, by comment over the bicuspid aortic valve.
Right.
Sometimes it is difficult to comment over the this aortic valve. So what is the best?
Short axis view at, like this is a short axis view at aorta.
Yes,
So if
yes.
you happen to look the opening of these valves, just zoom on these valves and you happen to see all 3 valves. And when the aortic valve open is a inverted triangle. You remember, like, I don't know, many of you must have seen that is a family planning sign was present way back in 1970.
Yes, yes, we have not had, sir.
You have not read. This was signed like, if you can look at my screen, this was the top one line and then bottom line, they were closing to each other.
Yes, yes.
So
Then
when the
it is
valve
fine.
will open, the valve will open like this kind of a sign. Inverted Benz sign.
Yes, yes.
Open inverted Mercedes Benz sign. It was in India's, like in 70s, I still remember very well. We were in school time this time, and the very well propaganda for family planning sign. I don't know where it disappeared with various political parties.
Yes, yes, yes.
So that is and in case of this, let me just show you, go back to this aortic valve. And once we see these aortic valves, they're opening up and closing, they give you a very good idea about the bicuspid or tricuspid aortic valve. Right? Any other questions?
Sir, can you show me the image of bicuspid aortic valve?
Okay, give me a sec.
And sir, any unicuspid if possible. I've never seen.
Oh,
Same here, sir.
Sir, is there quadricuspid aortic valve in by any chance?
I've got a quadricuspid, unicuspid, bicuspid. Everything is with me. Give me a second where they are. That's the question is. So I have to scratch my computer and to locate where are they. And I hope I could find them and show you in next couple of seconds. Okay. I think I've got it. I've got a complete armamentarium. Look, somebody steals up this laptop, they'll take away everything. I got it. All right. Lucky. Just a second. I'll have to. Can you see my slides? Any one of you?
Yes, sir.
Yes, sir. Yes, sir.
Good morning, friends. I'm Dr. Rakesh Gupta, who's going to take up all these bases. All right. Somebody was asking, how do we see a tricuspid valve? Here is in 3 dimensions echo, we can really look at this tricuspid valve. One is septal, anterior and inferior walls. We can very well see that. That's what we do number of time in our lab today. We look at these 3 leaflets separately. And why aortic valve is multi-directions? Suppose this is aortic valve, this is closed aortic valve. When it opens up, it opens at, like I told you, the jet in eccentric could be in this direction, in this direction, this in this direction. Any direction, the jet could be possible. So that's why we spend time when we have got an aortic valve stenosis in our day-to-day practice. So let me just show you those valves. This is a picture of dissection of aorta. I always teach is God has given us only one valve of aortic valve level. If you happen to see 2 valves at aortic valve levels, always think of dissection of aorta. There's one valve over here, second valve over here. So if you happen to look 2 valves in aortic area, then it is dissection of aorta. So this is unicuspid. Can you see this valve? This is rounded valve which opens like a round kind of a thing. So whenever the valve open, it just opens like this. This is a picture of CT scan
Uni.
picture of unicuspid.
Should always be associated with some amount of air.
Always, always. Now go back and look at this unicuspid aortic. This is how the valve is open. Now you see the hardly you see a leaflet out here. This is bicuspid. Now you can see the bicuspid valve which is opening. Only two leaflets which are seen. One over here, second is over here. And this is raphe, thickened raphe.
There is no bench sign.
No band sign. Now this is bicuspid in 3 dimensions transesophageal echo. Only one leaflet up, like it looks like mitral valve kind of a thing. This has got a stenosis as well as regurgitation. And aorta is majority of time is either high normal or dilated. Because this is aortic, bicuspid aortic valve is known as aortopathy. Is not called as bicuspid aortic valve. Then quadricuspid. Now concentrate. 1, 2, 3 over here and 4th over here. This is one valve over here. So when it's open, you can see it very beautiful. It's a quadricuspid aortic valve. 1, 2, 3, and 4. Here is one. Here is one.
But sir, just you said, why could it not be a flap of a dissection, sir? As you said, more than one set of valves.
I said flap of dissection will be 2 valves. One valve over here, one valve over here. I'm talking of the in the annulus. This is in the annulus. This is quadricuspid. And you know what is the routine aortic valve leaflets, 3 of them. So this is how it presents in a life, you know, like, I don't know, like for you, it could be like, I don't know why you are learning echocardiography. For me, it's like a passion. If somebody tells me at night 2 o'clock, there's interesting cases there, and you have to do echo, believe my words, I'll be the most happy person to do it. जैसे लेडीज को बता दो 80% डिस्काउंट लगा हुआ है तो वो कबर में से उठ के चली जाएंगे डिस्काउंट वाली. My wife keep on scolding me. My last month, my wife's birthday, and one store was giving 20% discount. It did not go at all over there. So that's how this echo is. And again, I'm saying the same thing. It gives you lot many diagnoses, unbelievable diagnosis. Anyway, that's just like life of echocardiography is.
Sir, one question, not related to AS per se, but like we have got those Lambel's excrescences over the aortic valve, and then we have got infective endocarditis, vegetations. What are the ways to differentiate? It is a
Anchal, very good question. If you have got infective endocarditis versus Lambel's excretions, look, the most important answer comes from our clinical judgments. If a patient of infective endocarditis would be there, what would be his presentation?
high grade fever.
Correct. Now you got the answer automatic.
Yes, sir. But like sometimes it will be below the leaflet, or like can there, or it can be anywhere.
Lambel's excretions is towards the aorta.
Yes. And vegetation can be either side, like
either side. Majority of time, vegetation is also towards the direction of blood flow.
Okay. Okay.
But they can move on either sides. Both of them can move on either sides. And today, when we are looking at vegetations, to be very sure, I could not locate that paper. The recent paper has published. Like we do a CT value of these vegetations. It's 1200 something CT score is there. HU values, hands down values are there. HU values are there, which differentiates vegetations with any other structure.
Okay.
I was trying to locate that particular paper today and I couldn't locate it. And when a few days back, I saw it when I was not looking for it.
Okay.
Hounsfield values. Sanjeev Mathur has, you perfectly said Hounsfield values, Sanjeev.
Sir, can I ask you a
Yeah,
question, sir,
sure.
please?
God, Pratibha, go ahead.
Sir, can LVH due to AS leads to aortic stenosis also?
LVH due to AS can lead to aortic stenosis.
Subaortic stenosis.
Yeah, it can. It can. Certainly, it can.
But
100%.
then, sir, how do we differentiate the gradients that it
Correct.
is due to
Very
subaortic?
true. Like now you're dealing with two subjects. One is subaortic stenosis versus aortic stenosis. Correct. So
Yes.
in aortic stenosis, the Doppler spectrum pattern I just showed you would be a sharper acceleration time and slower deceleration time. In subaortic stenosis, there will be superimposed. I showed you that pattern where inverted key slope shape pattern is inbuilt in Doppler flow pattern. So you'll be seeing two patterns together, one of aortic stenosis, another of alveolar gradients.
Okay. Okay, sir. Fine.
And so systolic anterior motion of mitral leaflet causing LVOT obstruction.
It could be present because what exactly happens, if you happen to remember, Achal, when we stand on a platform, there's a yellow line is always there on a platform. Have you seen, observed that?
Yes, sir. Yes, sir.
Why
Venturi
that yellow?
effective.
Why
We should
that
not
yellow?
fall.
No,
Like we should not fall into onto the track because
no,
once the train passes.
no. That yellow line tells you when the train passes at a speed over there, you can be sucked up towards the train.
Yes, sir. Yes, yes.
The same thing happens. That yellow line is like, suppose like a mitral valve. When LVOT gradient builds up, it sucks mitral valve into the LVOT. So you can have a systolic anti-emotion of mitral valve leaflets. It depends on pressures basically.
One question, sir.
Go ahead.
While they're measuring pulmonary wall, what all things we should mention in echo report? Because
We should mention pulmonic valve per se, thickened or non-thickened, any
it's
effective.
very difficult to say leaflet of pulmonary wall.
No, thickening you can see, definitely you can see thickening. Just measure 5 millimeter or more or less. And then you say that whether this systolic doming is present or not present. Then you say switch on a colors, turbulence present or not present. And then put a Doppler spectrum pattern to assess a peak velocity. And last, you can add pulmonic artery dilatation if it's more than 2.7 centimeters.
Okay.
One person I can appreciate that who has got a really passion for learning echocardiography is our friend from who's based in USA right now. He's from Jaipur and Hounsfield value. Can you tell your name? I just forgot your name. It's very bad memory.
Yes, sir. My name is Sanjeev Mathur.
Sanjeev Mathur.
Yeah. It's just interesting for me because although I have done MS in surgery, so my background is surgery, not medicine. So, but I really love echocardiography and I want to really pursue it.
So that's what known as passion, you know.
That's actually how to spend units, sir. It's always measured in units.
Yes, Hounsfield units.
HUs.
True. Next time I'll show you that paper because I was reading, I couldn't locate it today. I'll locate it again. And it's a very good paper which differentiates between vegetations versus other structures. And one more thing like that, Lambert's expressions. All right, any other questions before Piyush Pandey want to ask Dr. Subhash Chandra? Piyush, go ahead.
Yeah, good evening, sir.
Good evening, Piyush.
Sir, can you throw some light on that low flow aortic stenosis or something like that? I have read.
You are going to second, third steps. Please digest this much because I said the two fields which are keep on burning all the time is one of them is aortic stenosis. But I can tell you that
Okay.
Low flow, low gradient severe aortic stenosis is when the area is less than 1 centimeter square.
Mhm.
Your flow across aortic valve is less than 35 cc per meter body surface area, and the gradients are less than 4 meters per second.
Okay, sir.
So gradients are low, but area is high.
Hi.
It means what? It means something low flow,
Below.
low gradient, severe aortic stenosis less than 1 centimeter square area. This
Yes,
is known as paradox. When LV function appears normal.
Hmm.
It is said, like, we look at these people, they present to be in a very bad phase. It means they were having a normal LV function. Now their LV function is possibly deteriorated.
Yeah.
But we are not able to see that LV function which is deteriorated. Why? Because our cutoff guidelines for LV function is 50%. But all of us understand, if somebody develops a LV hypertrophy, what will happen to LV function? It will be high, 60, supernormal, 70.
Right.
So if that comes back to 55% or 56%, apparently it looks to be normal, but subclinical LV dysfunction is certain.
Right.
And these people are, what we do in this subset of population is we do a 2-dimensional stain. If the 2-dimensional stain is reduced, we always subject these people for surgery.
Yeah. Right.
Another worst part is these people, they do very poor with surgery also.
Okay, sir.
So the quest is, we should not look at the people going to low flow, low gradient, severe paradoxical aortic stenosis. We should be able to pick them up from early stage when they had high gradients. It means these are the people who were having earlier possibly high gradients and now has gone to low gradients.
Right. And sir, TEE will be better, 2D is better for the aortic stenosis.
Say it again. I'm sorry.
Transesophageal echocardiography versus 2D echo. I mean, transthoracic echography.
We hardly do transesophageal echo for aortic stenosis. Hardly. We rarely do it.
Okay, sir.
I showed you one case where we were puzzled, that patient had 2 times LVOT obstruction. And when we saw the Doppler flow gradient, that was masquerading as aortic stenosis.
Yeah, yes, sir. We have seen. Thank you, sir.
Right, Piyush. And Dr. Subhash Chandra, sir. Dr. Subhash Chandra, sir, any question? So I think let's stop it over here. It's almost 10:15 right now. I don't know, like I keep on going as long as you want.
Last question, sir, from your side. What is the role in the prognostic value of COAD? What is the value of echo in COAD progression? And how much they are improved by following on repeated echoes?
COAD means chronic obstructive airways disease, right?
Yes, yes.
Okay. What we do today nowadays is, if you appreciate, the two important things is COAD or COPD is the pressure gradient across tricuspid valve and the RV function.
Yes.
Correct. So do this time, next time when you have got a COAD patient, if it's obstructive lung disease versus restrictive, what do you do for that? You always do a lung function test?
Yes.
Do their echo before and do their echo afterwards.
Yes.
If your obstructive lung disease patient whom you did a nebulizer before, do an echo before giving a nebulizer and do an echo after doing a nebulizer, your PA pressure will fall.
Yes.
Second prognostic factor in these COPD patients is RV function. All of us understand, if the RV function starts deteriorating, these people, they do poor.
Yes.
Hemodynamically, they really do really poor. So whenever the RV function goes down, like their end is almost near.
Yes, yes.
So echo wise, we can follow up the RV function as well as the pulmonary pressures.
Because as the pulmonary pressure rises, they usually deteriorate very fast.
Very fast.
And no therapy is effective on that stage.
Correct. In fact, when they developed an RV failure, nothing happens. Nothing is severe to them.
Thank you, sir. Thank you.
All right, attendance time, man. Only few people are left, 59. Dr. Nitin, are you there?
Yes, sir. Yes,
Dr.
sir, I'm here.
Pratibha Dhingra. Dr. Pratibha Dhingra.
Sir, I'm here. I'm here.
Pratibha, are you there or not there? Dr. Veervar Kumar Jha.
Sir, I'm Dr. Nitin. I'm here.
Nitin, I have marked you up present already.
Yes, thank you, sir.
Dr. Jha from Patna. Ankit Saini, Panipat. Shashank Sunil Tuse, Nasik.
Yes, sir. I am present.
Shivaji Vitobhai Mali, Pune.
Yes, sir. Present, sir.
Harshvardhan Puri, Rajasthan. Pallavi Horo, Lucknow.
Present, sir.
Pallavi did not ask any question. Achal Dikshit, Lucknow.
Present, sir.
Saurabh Gupta, Udaipur. Saurabh Gupta. Saurabh, you are silent always. Okay, I have marked you present. Arnab Mandal, Madanapur, West Bengal.
Yes, sir.
Okay, Arnab. Avinash Solanke, Maharashtra.
Yes, sir. Present, sir.
Great. Sangeeta Chaudhary was present. Sangeeta, are you there?
Yes, sir. Present, sir.
Ashok Yadav, Delhi.
Yes, sir, I am present.
अभी आ रहा हूं.
Yes, sir.
Yes, यादव ठीक है.
Yes, sir.
पढ़ा है कुछ आज?
Yes, sir.
कल तेरी क्लास लेनी पड़ेगी मेरे को आगे. बिराटा देवरामा. बिराटा देवरामा अगरतला.
Yes, sir. Present, sir.
Present. Okay. Venkatesh Gowda present. Piyush Pandey present.
Present. Yes, sir.
Pankaj Mishra.
Present, sir.
Ajit Balasav Dangle.
Present, sir.
Kiran Birari Nasik.
Present, sir.
Rohtaj Singh Kalsi Gurdaspur.
Yes, sir. Present, sir.
Sandeep Delhi Mayur Vihar.
Present, sir. Sir, present, sir.
Prakhar Gupta Firozabad.
Sir,
Present.
present.
Present, sir.
Prakhar Gupta, sir.
Okay, dear.
Sir, Sandeep present.
Present. Mark you present, Sandeep.
Okay, sir.
Dr. Chitranjan Thatai, Katak. Sarada Prasanna Sahu, Katak. Subhash Chandra Vijayanagar Arya, Agra. Present, Dr. Subhash. Dr. Sofinar Islam, Assam. Pranjal Prakash Jagtap, Nasik. Deepak Suman, Rajasthan.
Yes, sir.
Rupali Sawant, Goregaon.
Present, sir.
Archana Kishore Sinalkar.
Present, sir.
Madhurima Datta, Silchar.
Present, sir.
Mahesh Padsalge, Navi Mumbai.
Present, sir.
Bhagat Vibhusha Vishwanath,
Present, sir.
Navi Mumbai.
Present, sir.
Done. Dheeraj Kumar Singh, Delhi. Dheeraj, are you there? Delhi has the more notorious people. You know. Sanjeev Mathur is present. Niranjan Agarwal,
Yes, sir.
Bhilai.
Present, sir.
Bhimraya D, Bangalore.
Sir, Niranjan Agarwal present, sir.
Yes, sir. Present, sir. Bhimraya.
Done. All three of you done.
Yes.
Sir,
Thank you.
Niranjan present, sir.
Gudade, Gangapur, Maharashtra. Rajesh Gudade. Rahul Kumar, Delhi. Rahul, are you there?
Yes, sir. Yes, sir.
Kartikeyan. Ravi Gupta. Ravikant Gupta. Dr. Subhash Chandra Mohali.
Present, sir.
Umesh Kumar Ojha is present.
Yes, sir.
Then Dr. Khushpreet Singh, Chandigarh.
Present, sir.
Amit Vikram Munger. Rashri Karat, Mumbai. Raj Rajinder Borkar.
Yes, sir.
Then Swapnil Datta, Chikli, Maharashtra. Parveen Kumar Danapur, Patna. Ravi Kumar Singh, Bhilai.
Yes, sir. Present, sir.
Dr. Prashant Pandey, Varanasi, present. Ankit Agarwal, Bareilly. Ankit Agarwal.
Yes, sir. Yes, sir.
Ravi Nilkant Patil. Sachin, Sanika Sachin Kadam.
Present, sir.
Anuj Kumar Devghar, Jharkhand.
Yes, sir.
Deepak Kumar Ghaziabad.
Yes, sir.
Dr. Niharika Chirola. Niharika. Dr. Vivek Kumar Dwivedi Loni.
Yes, sir. Present, sir.
Narendra Sharma. Dr. Narendra Sharma. Dr. Devendra Pratap Yadav, Varanasi.
Yes, sir.
Iqbal Mahmood, Dhaka, Bangladesh. Iqbal Mahmood. Shadab Raja.
Yes, sir. Present, sir.
Anuj Jain, Khargaon, Maharashtra. MAP, MP.
Present, sir. Present, sir.
Aarti Jadhav, Mumbai. Aarti Jadhav.
Present, sir.
Santosh Kumar Bardwan.
Yes, present, sir.
Sunita Kaul, Delhi, present. Paresh Alwani, Nasik. Paresh Alwani. Prasanjit Panda, present.
Present, sir.
Sheetal Bodke, Nasik.
Yes, sir. Present.
Dr. Raghvendra. Dr. Prakash Raichur, Karnataka. Dr. Niharika Terhan. Amit Kumar Singh.
Present, sir.
All right. Anybody else left?
Sir, Niranjan Agrawal from Bhilai, present, sir.
Sir,
Niranjan Agarwal from Bhilai. Just a minute.
Sir,
my-
Rajeshri Kharat from Mumbai, sir.
Oh, Rashi, where you were sleeping at that time?
No, sir, sorry, sir. I just made it. Sorry.
Okay, I marked you present, Rashi.
Hello, sir. Niranjan Agrawal, sir.
Thank you, sir.
Niranjan,
Thank you.
just a minute, one by one, man. I cannot locate the people's name, you know. Rashri Karat. Just let me look at first Dr. Rashri Karat. Present. Done. Second one is
Niranjan Agrawal from Bhilai.
Niranjan Agrawal from Bhilai. निरंजन सो जाते हो आप भी बीच बीच में यार.
No, sir. I told my attendance, but my attendance is overlapped with someone else, sir.
Male or female?
Male, sir.
Okay. I have marked you present already, Niranjan. Anybody else?
Okay. Thank you, sir.
Sir, Prashant.
Prashant Panda.
Prashant Pandey, sir. From
Done,
IIT.
done. Kerala.
No, sir. That is Prasenjit, Kerala.
Prasanjit, Kerala. Okay. Prashant, just a second. Prashant Panda. Varanasi. I marked you present, Prashant.
Sir, can you hear me? Rajesh.
आवाज नहीं आ रही.
Narendra Sharma, sir. Present, sir.
नरेंद्र शर्मा प्रेजेंट. अब कहां से उठ के आ गए नरेंद्र? आप सो गए थे?
नहीं सर, वो कुछ ऑडियो में प्रॉब्लम हो रही है.
कहां पर?
ऑडियो में कुछ प्रॉब्लम हो रही है सर.
अच्छा, ऑडियो में कुछ प्रॉब्लम. चलो ठीक है. नरेंद्र, वेयर डू बिलोंग टू?
सर, फ्रॉम दिल्ली, सर.
Delhi. Delhi are notorious people, you know, including me. All right, guys. Next week we'll have one of the finest personality of the world. And I always call him an international father of echocardiography, Dr. Nanda from USA, talking about mitral and aortic regurgitation. Very fine man. I always admire him. I learned so many things from him. And he was emeritus professor at University of Alabama. And he's a founder of that echocardiography journal, which is published from all over the world for those people. Is a regular monthly journal, monthly or weekly journal nowadays. So we'll have his presence. I'm sure like many of you would like to listen to him and take his, I always take his blessings whenever he's there in these programs. So with these few words, let me tell you goodbye, sweet good night, and stay safe. See you next week alive. Bye-bye. Take care. Good night.
Thank you so much.